Thank you for coming to the launch of the IAS Lancet Commission on the Future of Global Health and the HIV Response. And I'd ask you just to take your seats now so that we can commence the proceedings. Thank you very much. Well, thank you. I'm going to start, and I really want to thank you all for joining the International AIDS Society and the Lancet at the launch of their new report. And you will have received the report in your conference bag when you registered, and I hope that you have read all 25,000 and something words. And following myself, I'm delighted that we have with us today one of the editors of the Lancet, Pam Dass, who will be giving some remarks, and of course my fabulous co-chair of the Lancet, IAS Lancet Commission that you see in front of yourselves, Chris Byra. But I thought I would just kind of, as people are taking their seats, I would just give you a little bit of background as to how we got to this position from the International AIDS Society's point of view. And I think over at least once a year, we meet in either Geneva or the place of the current president's location to have a retreat. And at those retreats, we think about the response of the HIV, we think about our membership, and we think about all things pertaining to the HIV response. And over the most recent years, a few things have really concerned us. One has been the sense of, if you like, a premature triumphalism, I think some people may call, where we have an interpretation of some of the goal setting that has been made in the world today has resulted in people thinking that the HIV epidemic is in hand and under control. And that has deeply concerned us at the IAS because many of us are physicians, many of us are researchers, there are some of us who are community activists. All of us are concerned that we really do sustain a response that does see the end of HIV. And you will have heard many times at this conference that we are currently not, contrary to that concept, we are not on target to meet the goals set by the UN in terms of the 2020 or the 2030 at this moment. Spectacularly, in fact, there are 50 countries around the world where the incidence is not going down, it's not staying steady, but actually increasing. And that must give us all reason to stay up at night and be very concerned. We know that if we are not moving forward with our response, then we are definitely sliding back. And it was with that concept that the Governing Council and the IAS Secretariat came together to say, what could we be doing? And I really pay tribute to Chris's amazing leadership in this regard, in that he said, we need to take a stand as leaders of yourselves and as opinion makers within the greater body to say, what do we believe needs to be done? And I will leave it to Pam and Chris to explain exactly what the content of this commission was. But second to the notion that we are not done, I think there was a real feeling that we needed to be part of a solution, that we would not just complain that, you know, we need to take stock and regenerate ourselves, but that we should find a solution to the problem, a solution that would create a sustainability to the response that otherwise may not be there. And I want to remind you that this week, while we are standing here in Amsterdam this week, around about 2,000 young women and girls will become infected with HIV in South Africa, my home country, alone, just this week. And those young women will need antiretrovirals for at least 40 to 50 years hence. So at the very least, we are around for, at least half a century and patently more. And as we've heard time and time again, that funding is unpredictable. Politics are unpredictable. It behoved us, we believe, to find a more sustainable response. And it is with that in mind that the IAS congregated a group of passionate HIV-ologists, if I can call them that, and sought out like-minded experts within the global health field to say, how can we join hands to write down some of these concerns and some of these suggested solutions to be able to present here at AIDS 2018. I will tell you it has been a sprint, even though it has been a 2-year sprint or maybe even a 3-year sprint, but it has been a sprint to get to this point. And again, I want to pay tribute to Chris and the commissioners for meeting the target of AIDS 2018. I want to thank Pam, because I know this added a bunch of, very anxious moments to her life, that we would in fact meet this target. And so I actually want to thank the both of you that we are here today, and we do have a hard copy of the commission in your book. So thank you for that. We have a wonderful lineup, so without any more ado, I'm going to hand over to Pam to ask her to make the first remarks. Thanks.
Okay. Good evening, everyone, and welcome. As Linda says, I am the Lancet's Global Health Editor and was the editor for the Commission's report. Unfortunately, Richard Horton, who was originally scheduled on the programme, is unable to be with us tonight, so I am stepping into his shoes. But in the current climate, as an Asian woman in global health, perhaps a good thing for panel parity. So I thought I would break my opening remarks into sort of 3 parts. First of all, I thought I'd start with saying something about our global health work and these reports that we do. I know for this audience, The Lancet is familiar to many of you. We are a global medical journal that pays considerable attention to global health issues, viewed through the lens of health equity, social justice, and human rights. Back in 2003, we began to publish in-depth articles aimed at spotlighting neglected or emerging areas of global health and tackling topics where there is contention that is hindering progress. These reports have involved working in partnership with a range of experts to define the scope of the problem, the causes, and the potential solutions. What we've learned from our work over the years is that global partnerships deliver impact, and that bringing together the best available science can be used as an instrument to provide reliable knowledge for social and political action. We see ourselves as a vehicle for science-based advocacy. So this commission, as Linda said, was formed 2 years ago in 2016 with the aim of really taking a wider view of how HIV will be situated in the global health space in the next phase of the response, and as we have now become part of the Sustainable Development Goal era. On its 2-year journey, the Commission has had to really grapple with the many challenges and opportunities facing the HIV response today, and the relationship between the HIV community and the broader global health agenda. I'd like to thank Chris and Linda for their extraordinary leadership and energy on this commission, and indeed all the commissioners for their contributions. This is the 5th HIV report, Chris, that we've worked on. And as always, he and the team he brings together are rigorous scientists and thought leaders who are incredibly inspiring to work with. So on the Commission, well, I think this is a bold, compelling, and overdue report. It's the first time that some of the great leaders in the HIV/AIDS movement recognises there needs to be a course correction. And this commission initiates a dialogue on what that course correction might be. Over the next hour, you'll be hearing about the findings of the report, and as Linda said, you should all have a copy of the report in your delegate bags, but there are extra copies at the back of the hall as well. But before I pass over to Chris and the team, I'd like to share some thoughts from a discussion that Richard Horton and I have been having on the current state of global health, which I think is really quite important for this work and the next steps. I've only been at this conference the past 2 days, but in that time I've been in sessions or in conversations that underpin the sentiments that prompted this commission. And they are the many threats that we in global health are faced with today. Global health is under attack. Human rights, social justice, equity, the very foundations of the work we all do are slowly being dismantled. If we look back at the Millennium Development Goal era and contrast that with the current Sustainable Goal era, it's clear that, quote, health in global health depends so much on the political conditions of our time. Back in 2000, in the MDG era, there was the Okinawa G7 summit, which was the first time leaders took up the issue of infectious diseases. These discussions led to the establishment of the Global Fund to fight AIDS, TB and malaria in 2002 and contributed to the achievement of the Millennium Development Goals. Then there was the G7 summit in Gleneagles, led by our UK Prime Ministers, Tony Blair and Gordon Brown, who continued the support for health and development with a renewed commitment to Africa. There was the Commission on Macroeconomics and Health, which had one simple central message: invest in health substantially and economic development will follow. That report was credited for successfully raising the profile of global health in the international arena and promoting the long-neglected link between health and wealth, such so that for a decade, donor investment in health was exponential. There were intellectual leaders arguing about health and development. There was an engaged and benevolent US government, and PEPFAR was born out of that. And then, and most importantly, there was the AIDS movement, which was incredibly powerful and transformed the global health landscape. But many of those conditions of the past decades sadly don't exist anymore, yet we're carrying on in global health as if they still do. And yet now, more than ever, do we need those conditions. We are confronted with a serious global crisis in the context of both the immediate term and longer term sustainability. We have a US administration that is determined to oppose any global public good, divisive in its policies both at home and abroad. In the UK, we are wrestling with the recklessness that is Brexit and the EU uncertainties that come with it. We don't have a strong GS government currently leading on health, and the AIDS response, as we have heard repeatedly, is not on track, with the epidemic at serious risk of rebounding. So if we look at the political context, this really is not a good time for global health. We're all being urged to be optimistic and positive, but actually we're facing a very destabilizing time, and it's unclear how long that's going to last. So what do we do? Is it business as usual? No, I don't think it can be. We have to prepare for the future. But what are the conditions we need to create for this future? Where will the intellectual leadership come from? How do we reignite multilateralism? And again, more importantly, how do we get back to the anger, the passion and collective action of the AIDS movement? And how do we link that back to global health? What is the grand narrative for today, and how do we all write it? These are questions that we must confront and think about collectively. As we continue this Commission's work and reconfigure the direction of travel, we need to work out practical solutions and come up with what this transition is going to look like, and for the words of this Commission to be transmuted into deeds. So I'll leave you with these thoughts, and maybe we can revisit some of those broader questions in the panel discussion. But I'll now hand over to Chris.
Well, good evening, everyone, and let me join my wonderful co-chair, Linda Gale Becker, in welcoming you all. And I must say, it's also so wonderful to see so many of the commissioners here this evening, and so many of the people who participated in this. I am actually going, because I'm not sure that it will happen again, and I think it's really, really worth doing. I am going to just name for you now everyone who has served on this commission. And there are a number of very special people who have to be named, but I must add one particular one, which is that if you're going to take one of these things on, make sure you have a skilled scientific writer who knows the field and knows what you're doing, and that is Mike Isbell. And we would not, yes indeed, we would definitely not have made a number of these deadlines without Mike's extraordinary fluency and also his incredible speed. So thank you so much. So here you go. Are you ready? Linda Gale Becker, Sir George Allen, Steph Barral, Javier Cepeda, Dimitri Daskalakis, David Dowdy, Mark Dybel, Serge Elohi, Kene Essom, Jeff Garnett, Anna Grimsrud, James Hakim, Diane Havlier, Mike Isbell, Lee Johnson, not Leah, we've changed his gender up there, Adiba Camarulzaman, Parastu Kasai, Michelle Kazachkin, Nduko Kilonzo, Michael Clegg, Marina Klein, Sharon Lewin, Chewi Luo, Coletzo Makofane, Natasha Martin, Kenneth Mayer, Greg Millett, and Tobeko Ntusi, Lois Pace, Carrie Pike, Peter Piot, Anton Pozniak, Tom Quinn, Jürgen Rockstro, Jarer Radivosian, Owen Ryan, Sarah Sippel, Bruno Speer, Agnes Sukat, Ann Stars, Stephanie Strathdy, Nick Thompson, Stefan Ovella, Mauro Schechter, Peter Vickerman, and Brian Weir. Is that a list or what? I mean, so as you've heard from Linda Gale and Pam already a little bit, the idea here was both to think about advances in global health and strengthening the HIV response, and to really do those things together, to look for the synergies, the win-wins, and to do so as we have always done in the HIV movement and tried very much and done as well in the wider global health movement, which is to be evidence-based, to review the existing world literature, to look for the best evidence and the best practices, to try and synthesize a great deal of information, hundreds and hundreds of recent scientific papers and reports, and to pull that together and really try and find coherent ways of thinking about what more integrated HIV responses might look like. And to do that, of course, as you can see, in the era of the Sustainable Development Goals. This is the cover of the Lancet IAS Commission. I will admit to you that the designers of this were my mother and I, and we actually struggled, and Pam and I talked about this at some length. No one image could capture the complexity of what we were trying to talk about in this undertaking and think about. And so what you see there are a range of different aspects of what different kinds of integration look like. There are people who inject drugs in Tehran there. There are elders in a clinic in Mozambique with diabetes learning how to use an app that was initially developed as an adherence app for antivirals. And so HIV helping to lead the way for an important global health condition. There are mothers who are cooking in a very squalid setting because their children are in a hospital, and that is a symbol for us about health systems and why they really do need to be strengthened. There are some marvelous youth leaders who are there saying AIDS will be defeated, and actually those guys are at the Melbourne IAS conference. There's a sex worker from Bangladesh in front of a brothel, and there's a group of young people calling for the right to contraceptive access in a flash mob in Uganda. That's what we're talking about. I've already done the work of listing, reading everybody's names. There they all are. I just complained to Pam that the Lancet font is getting a little small for some of us as we age. So what have we called for? Well, there are a couple of things, and the first and most important is, of course, as Linda Gale and both Pam alluded to, we are in a challenged period where we have seen declines in funding for the HIV response, and that is premature. Everybody in this room knows we are not done with this epidemic. We are not going to be for a good while, and it is much too soon to defund the HIV response and to move away from the incredible focus that has gotten us as far as we have. We have 17 million people at least living in the world with HIV who are not on treatment, and nobody's going anywhere until we get universal access for all of them. We also have some other demographic trends, some of which are actually the success of global health and child survival 20 years ago. This is the world's largest cohort of adolescents that's ever lived, and that is something really to be celebrated, but that also means that they are coming into the most at-risk years for HIV acquisition and transmission, and so we really have to redouble our efforts. We looked at providing, and you're going to hear the models of a number of these, integrated, co-located services for HIV and related health conditions. And the most obvious one, and one we have been talking about at least for 3 decades, is tuberculosis and HIV. It's extraordinary that we still haven't achieved the goals of better services integration there. And of course, we all know TB still accounts for 40% of the deaths in HIV. We need to integrate those kinds of services for the most underserved populations and key populations. Ken Mayer and Dimitri Daskalakis helped us think about this for gay men and sexual health and what integrated services look like, and that is really a critical part of what it is we need to do. And we need to think about HIV and non-communicable diseases because, first of all, as so many of the providers in the room know, many of our patients are aging. They are aging with HIV, and they are having many of the complications of aging and many of the complications of long-term viral infection. And so there is real common cause to be made now between HIV and non-communicable diseases. And of course, non-communicable diseases are not diseases only of the first world. Most of the deaths are occurring in low and middle-income countries. So we really feel that perhaps the biggest bottom line message is that the HIV response, for which many of us have given our lives and many decades, really can benefit from a broader global health engagement. And we hope that this commission serves as a step forward in real global health solidarity. There are a number of funders who have made this work possible. We have to acknowledge the Bill and Melinda Gates Foundation, the Ford Foundation, the Elton John AIDS Foundation, the Center for AIDS Research at Johns Hopkins University, which is funded by the National Institutes of Health, and of course, we always have to acknowledge the Lancet. Our partnership, which has been going on since we prepared for Vienna in 2010, and we did the special issue on HIV among people who inject drugs, people who use drugs. That means we started in 2008. This is the 10th year anniversary. Yeah, so congratulations and thank you deeply for that engagement. And now, Linda Gale is going to take over and chair and introduce the extraordinary group of young people who modeled what we're talking about. So this has all been kind of big picture and broad. Now you're going to actually hear some of the fantastic science that has been done by these spectacular young scientists. Linda Gale.
Great. So thank you, Chris, and thank you for those great remarks. I'm going to ask Pam, if you want to go and sort of view this from down there, you're very welcome. Otherwise, I'm going to ask the modelers to come up. And whilst you guys are coming up, I'm going to give short bios just in the interest of time. So do move up. Javier Cepeda is a PhD MPH, assistant professor in the Division of Infectious Diseases and Global Public Health at the University of California, San Diego. His research focuses on the intersecting epidemics of HIV and hepatitis C, substance use, and criminal justice involvement. And you will see his amazing understanding of, for example, the Russian epidemic. Lee Johnson is an epidemiologist at the Center for Infectious Disease Epidemiology and Research at the University of Cape Town. Lee's particular interest is in the use of mathematical modeling to understand disease dynamics and to simulate the impact of disease control programs. And he will talk more about the Tembisa model, which is well known in South Africa. Parastu Kasai, PhD, is a research associate at the Johns Hopkins Bloomberg School of Public Health. She's trained in the field of engineering and operational research, and her research focuses on the development and analysis of computer simulation models of infectious disease in human populations. Brian Ware, PhD, is an assistant scientist at Johns Hopkins Bloomberg School of Public Health, and Dr. Ware's research focuses on HIV prevention. His current HIV-related research includes needs assessments among Baltimore needle and syringe exchange clients and other people who inject drugs in Baltimore. He's also interested in PrEP and male sex workers in Thailand. So I think you'll agree, an extraordinary lineup of young and emerging scientists, and I'm delighted to start with Javier. Thank you.
Thank you, Linda Gale. So it's my pleasure to provide an overview of the modeling exercises that were featured in the Lancet Commission, and also to speak about our own team's work on modeling harm reduction interventions among people who inject drugs in Russia and looking at the dual benefit on HIV incidence and fatal overdose prevention. So 5 sites were selected that were featured in the report, looking at the impact of HIV integration, and Dr. Lee Johnson will be speaking about the application of the Tembisa model on what kind of impact a mobile multi-disease screening intervention would have for HIV and non-communicable diseases on diagnosis and treatment of HIV, hypertension, and diabetes. Dr. Parastu Kasai will be speaking about her application of the Spectrum model, looking at, in Kenya, a community screening campaign for HIV, diabetes, and hypertension, looking at what kind of impact it would have on reducing HIV incidence and mortality, diagnosis and treatment of hypertension, diabetes. And also in Nigeria, looking at expansion of preventing mother-to-child transmission and access to contraceptives, and what kind of impact that would have on reducing HIV incidence and diagnosis in infants, unwanted pregnancies, and maternal and infant morbidity and mortality. And in India, looking at a community screening campaign for treating HIV and syphilis among men who have sex with men and female sex workers, and what impact that would have on reducing HIV incidence and mortality and increasing syphilis diagnosis and treatment. And Dr. Brian Weir will be speaking about the cost effectiveness of these interventions in Kenya, Nigeria, and India. And I'll be speaking about, like I mentioned earlier, the impact of harm reduction and ART provision for people who inject drugs in 2 Russian cities, and looking at what kind of impact it would have on reducing HIV incidence and fatal opioid overdose. So as many of you are aware, the HIV epidemic in Eastern Europe and Central Asia is quite dire. It's the only region in the world where the epidemic is expanding. Most of these new infections are occurring in Russia, which is still driven primarily by injection drug use. A recent paper that was published in PLOS Medicine showed that there's an outbreak occurring in the Siberian region with new diagnoses ranging from 130 to 230 cases per 100,000 population. I've circled here the region that our modeling will be focusing on. In terms of HIV prevention programs targeting people who inject drugs in Russia, the quality and coverage is quite poor, and most of this has been due to policies that are fueling HIV transmission. So, for example, non-naltrexone-based medication-assisted therapy, such as methadone and buprenorphine, remain illegal. Needle syringe exchange programs are legal, but coverage is minimal, and they receive practically no government support. Only 1 to 3 syringes are exchanged per person who injects drugs per year. By comparison, high coverage would be something observed in Australia, where more than 200 syringes are exchanged per year. And this has also been precipitated by a substantial decline after the Global Fund withdrew in 2010. Also, ART coverage is quite low among people who inject drugs. In terms of epidemic modeling, there's been one study that has indicated that harm reduction could have a large impact on HIV epidemic among people who inject drugs in St. Petersburg. However, this city and setting is quite different than the regions that I'll be talking about. So the aim of this analysis was to model the potential impact of scaling up HIV prevention interventions such as MAT, NSP, and ART on incidence of HIV and fatal opioid overdose among people who inject drugs in 2 epidemiologically distinct settings in the Siberian and Ural mountain region of Russia. So we developed a dynamic deterministic compartmental model of HIV that included both injection and sexual transmission risks among people who inject drugs. It was stratified by HIV disease stage and ART status, including loss to follow-up. So people entered model susceptible, and if they became infected, they would go through the different stages of HIV infection, as shown in the figure, and when they can also go on to ART and drop off ART. And we also obtained local data from Omsk and Yekaterinburg, and we were able to identify important correlates of prevalent HIV infection, and we used them to stratify the model. So we stratified based on sex and also low and high risk, which we define as having ever being incarcerated, the high risk group. And it was also further stratified by whether or not they were on the harm reduction intervention, and they could drop off based on the type of intervention that they were on. So, as I mentioned before, we chose one setting in Siberia, and we chose Omsk, and there's been an increasing HIV prevalence that we've observed. For example, in 2009, the prevalence among people who inject drugs was at 9%, but within 6 years, it had already more than doubled. In Yekaterinburg, it's been a stable but very high prevalence among people who inject drugs. Within the past 10 years, about 60%. Scenarios that we focused on, we had 6, with the base case being no harm reduction, so kind of the status quo, and also we assumed that ART coverage was 26% that we calibrated to the year 2014. In terms of harm reduction, scenarios 2 through 5 focus on different harm reduction interventions, such as needle syringe exchange programs, so what it would look like if coverage reached 50%, MAT 25% and 50% coverage, and then an integrated harm reduction scenario where combined prevention intervention. And this integrated harm reduction in scenario 6, integrated harm reduction plus an ART expansion, so it's basically scenario 5 plus tripling the ART recruitment rate among those who are infected. These are the key assumptions of the different effects estimates that we used for our model. I do wish to note, so most of these, or all of these estimates did come from large global systematic reviews and meta-analyses. I do wish to note the important impact that non-naltrexone MAT has on reducing overdose mortality. So the recent meta-analysis found an 80% reduction in mortality for those that were on MAT compared to those who weren't. And of course, ART increases life expectancy and decreases sexual transmission risk and also injection transmission risk. So these are the model projections looking at the impact of this integrated harm reduction intervention on HIV prevalence among people who inject drugs. So as you can see in Omsk, in the gray solid line, that's the base case. So assuming no intervention, we would expect it to reach in 10 years around 35%, but it could be as high as 50%. And in Yekaterinburg, assuming no intervention, the base case we would assume it to be still around 60%. Obviously, the intervention that had the most impact was the integrated harm reduction plus tripling of the ART recruitment rate, which is shown in the orange line there. So in terms of the proportion of HIV cases averted over 10 years, scaling up either NSP or MAT to 50% coverage could avert a median of 35% new infections in Omsk and around 20% in Yekaterinburg by 2028. if we look at this integrated NSP and MAT scenario plus an expansion of ART, scaling up to about 65% coverage by 2028, it could avert 53% of new infections in Omsk and 36% of new infections in Yekaterinburg over a decade. So another outcome that we looked at was opioid overdose deaths. So what we found was that high coverage, so where 50% were receiving non-naltrexone MAT, that could avert about 1/3 of fatal opioid overdoses in both settings. So just to conclude, high coverage NSP and MAT in combination with ART to reach 50% would have a dramatic impact on reducing the number of new infections in these two cities. Changing the policy and legalizing MAT would also have a substantial impact on also not just on HIV, but also averting about 1/3 of fatal opioid overdoses. So just to bring it back to where we began, so in Russia there is an urgent need for legal changes and capacity building to provide basic health services for people who inject drugs, ideally in an integrated program which could reduce HIV, and these programs are also effective in preventing hepatitis C as well, and fatal overdose. So I'd like to acknowledge my terrific team of collaborators and mentors at the University of California, San Diego, terrific team at NGO Stelit in St. Petersburg and the Russian Healthcare Foundation in Moscow, University of Bristol and Johns Hopkins, and of course our funders, National Institute of Drug Abuse, National Institute of Allergy and Infectious Diseases, the Elton John AIDS Foundation, International AIDS Society. And if you'd like to know more about the technical details of our work, I advise you to consult the supplementary material in the Commission report, and also to see our Lancet HIV paper that also recently came out, where we explored other scenarios as well. Thank you.
Thanks, Thank you. And as mentioned, all the details are online in the supplemental material. But I'll ask Lee now to come and tell us about the modeling from South Africa.
Okay, thank you. So I'm going to be presenting this evening on work that we've been doing on modeling the integration of HIV testing with screening for other NCDs, particularly diabetes and hypertension. These three diseases are really contributing very substantially to the burden of disease in South Africa. As I'm sure you're all aware, South Africa is the country with the largest HIV epidemic in the world. UNAIDS estimated that in 2016 there were 7.1 million HIV infections. Our most recent National Household Survey has put that number at 7.9 million. We also have very high rates of mortality due to diabetes. Diabetes as a cause of death has been increasing steadily since 1997, and in 2012 it was estimated to have accounted for about 3.6% of all deaths. It's consistently been amongst the top 5 reported causes of death in South Africa in recent years. We also have a very high prevalence of hypertension in South Africa. A 2012 national survey estimated that the prevalence of hypertension was 32%. Hypertension is the leading cause or the leading risk factor for cardiovascular disease. And cardiovascular disease, together with HIV and diabetes, was estimated to have accounted for more than half of all deaths in South Africa in 2012. In South Africa, we've seen that there's been quite a lot of progress made in terms of scaling up access to HIV testing and HIV treatment. But unfortunately, we haven't seen the same progress made in terms of scaling up treatment and diagnosis for the NCDs. And you can see that in this next slide, where we're comparing these three different diseases in terms of levels of engagement in HIV care. So if you look at HIV first, you can see we're estimating that in 2016, about 87% of all HIV-positive adults were diagnosed. That compares to only about half of diabetes cases and hypertension cases. The dark blue bars are representing the fractions of people who are on treatment and controlled on treatment. So in the case of HIV, that would mean having a suppressed viral load. We estimate that in 2016, that fraction who were on treatment and suppressed was 42% for HIV, compared to only 17% for diabetes and 12% for hypertension. So there's clearly a need for improved screening and treatment for diabetes and hypertension. So what we were really trying to do here was to estimate the potential benefits of a multi-disease screening program in South Africa. We've used the Tembisa model, which is a combined demographic and HIV model that was developed specially for South Africa. And we've used the model to estimate what would be the impact of a mobile, community-based multi-disease screening program for each year from 2018 up to 2028. This is an age and sex stratified model, so we used data from the SEARCH trial to estimate relative rates of uptake of screening by age and sex. The SEARCH trial, as I'm sure many of you will know, is a similar multi-disease screening program or trial that has been done in Kenya and Uganda. The model was also used to estimate the effect of this multi-disease screening program in terms of HIV infections averted. We've assumed that the screening program would reach 10% of the population per annum on average. We've also estimated the fraction of the population that was previously diagnosed by age and by sex using the Tembisa model in the case of HIV. And in the case of diabetes and hypertension, we've used a 2012 national survey to estimate those age-specific rates of previous diagnosis. And then we've estimated or assumed rates of linkage to treatment after diagnosis based on two sources. In the case of diabetes and hypertension, we've used data from a pilot program that was actually led by Linda Gale's group in Cape Town, which also involved mobile testing. So we've used the results from that study to set the assumptions around rates of linkage to treatment for diabetes and hypertension. And in the case of HIV, we've relied on the results of a systematic review by Monisha Sharma. And I should say that these studies that we've relied on have generally found quite low rates of linkage from diagnosis to treatment, typically around 40% in the case of community-based testing. And so we've been fairly conservative in terms of what we've assumed about rates of linkage from community-based testing to treatment. A lot of other modeling studies have been more optimistic in those assumptions. So this slide is showing the model estimates of the yields from multi-disease screening. The light pink bars are representing the expected prevalence of disease. The darker pink bars are representing the expected fractions of people tested who would be newly diagnosed, and the red is representing the proportion who would be newly diagnosed and started on treatment. So you can see that that fraction is fairly low in the case of HIV, higher in the case of diabetes, and highest in the case of hypertension. So we're saying the benefit of this multi-disease screening program would probably be smallest in the case of HIV, but that's really because so many of the HIV cases have already been diagnosed in South Africa. We can also express the results of this modeling in absolute terms. So if we look in terms of absolute numbers of new diagnoses and patients treated, it comes to 492,000 new HIV diagnoses and 197,000 new patients on ART. We also estimate 1.2 million new diabetes diagnoses and 543,000 diabetics newly treated. And most significantly, 6.35 million new hypertension cases diagnosed and 2.1 million new hypertension patients treated. We also estimate that this screening program would avert about 69,000 HIV infections over the period from 2018 to 2028. So that's equivalent to about a 3.5% reduction in HIV incidence. And that's being driven by the model assumptions about reductions in risky behavior after people have been diagnosed, as well as the reduced infectivity once people are on treatment. So basically, we've been modeling a mobile multi-disease screening strategy for HIV and other NCDs. We've used the Tembisa model for South Africa, and the main outcomes that we've been interested in are new diagnoses and treatment for HIV, diabetes, and hypertension. What we've seen is that in South Africa, relative to HIV, levels of screening and treatment are pretty low for the non-communicable diseases. So platforms that integrate screening for HIV and NCDs have the potential to address the need for improved diagnosis for hypertension and diabetes. But I think it is also important to remember that diagnosis is really just the first step in the treatment cascade, And we also need to invest in improving the quality of treatment for diabetes and hypertension. We are not going to be able to absorb and retain those newly diagnosed hypertension and diabetes cases if we don't improve the quality of treatment. So we should really be aiming to improve on that 40% rate of linkage from diagnosis to treatment. But we can only really do that if we substantially improve on the quality, the general quality of healthcare services in South Africa. And that is all I have. Thank you very much.
Thank you. Thanks, Leo.
I just have to say that our immediate past dean of the Johns Hopkins School, Mike Clegg, who's one of the commissioners, is here, and he's a world expert on the epidemiology of hypertension. And so doesn't that make you happy, seeing all those diagnoses and treatment? He's delighted. I'm so glad.
Thanks, Chris. So thank you, Lee. We now turn to Parastu, who's going to take us through the work from India, Kenya, and Nigeria.
Thank you. Well, thanks everyone for the great introduction. It's a pleasure being here. As mentioned, our team was tasked for modeling the impact of integrating services for HIV and other healthcare sectors for 3 countries of Kenya, Nigeria, and India. In this presentation, I'm going to provide an overview of our methods that was applied for this analysis and also the epidemiological impact of interventions. And in the following presentation, my colleague Brian Veer will cover the costing aspect of this study. Kenya has the joint 4th largest HIV epidemic in the world, and compared to the analysis that was just covered for South Africa, it differs in terms of lower HIV prevalence among adults as 5.4%, but at the same time higher proportion of undiagnosed HIV at about 30%. In recent years, Kenya has been suffering from an increasing burden of NCDs, now accounting for about 27% of all deaths and over 50% of hospital admissions. Much of this burden has been attributed to late diagnosis and poor treatment outcomes. More than 56% of Kenyans report that their blood pressure have never been measured, and among those with a diagnosis of high blood pressure or hypertension, only 22% are taking treatment. All of these motivated our analysis for considering a very similar situation for integrating services of HIV with NCDs, including diabetes and hypertension for the Kenyan, similar to the analysis that was offered for South Africa. As far as the modeling platform, we applied the Spectrum package developed and maintained by a Veneer Health company. Spectrum, for those of you who are not familiar with it, is a set of policy-making tools that provide policymakers with analytical methods to support decision-makings. We applied the aims and goals model that are designed for modeling HIV epidemic in different countries. For each of these countries, we developed 2 sort of parallel interventions and 2 parallel scenarios. The first scenarios represent baseline, which is just business as usual, the status quo setting when we don't change the current ART coverage and just continue things forward for over the next decade. For the intervention scenario in Kenya, we modeled a joint community outreach campaign based off Project Surge, basically targeting a geographically distinct area of Kenya on an annual basis comprised of 10% of population. We assume that this intervention can successfully reach to 90% of individuals, screen them for HIV, diabetes, and hypertension, and we also assume heterogeneous level of uptake in ART treatment and treatment for diabetes and intervention based on existing study from the literature. In this slide, I'm presenting the overall impact of interventions on HIV-related outcomes, both in terms of number of new HIV infections and number of AIDS deaths averted. So the baseline model projected a gradual decline in the rate of HIV infection in Kenya over the next decade by about 13% in 2028. When we implemented the scenario, we modeled a gradual increase in rate of ART coverage among Kenyan adults, which indeed resulted in 44% reduction in rate of new infections, averting about 260,000 new infections and over 244,000 HIV-related deaths. All of these corresponded to marginal improvement to HIV prevalence at about 1.4%, given the fact that those infected with HIV will be aging over the next decade. As far as projected effect on the NCD's outcomes, we projected immediate impact on the cascade of care. Only after 1 year of program implementation in the treatment-centered communities, we observed substantial increase in treatment outcomes, increasing from 10% to 47% for diabetes and 8% to 27% for hypertension. Over the course of 10 years of this intervention, the program was able to identify over 686,000 individuals with untreated diagnosis of diabetes, and also over 7.5 million individuals with untreated hypertension. So to move forward with this discussion, the next country that we considered was Nigeria, which has the second largest HIV epidemic in the world. Compared to Kenya and South Africa, Nigeria HIV epidemic suffers from low levels of PMTCT, which is prevention of mother-to-child transmission of HIV for HIV-positive pregnant women. This results in substantial levels of HIV vertical transmission, estimated about 75,000 infants diagnosed with HIV in 2016. In this setting, there is also low coverage of contraception methods and all reproductive health services for women. Less than 15% of Nigerian women at reproductive ages report taking contraceptive, and among married women, 16% have unmet need for contraceptive. All of these motivated an analysis regarding integration of HIV services and reproductive health for Nigerian women in this setting. Using a spectrum model, we developed a baseline analysis in which we maintained the current reported level of PMTCT at 26% and contraceptive coverage at about 15% among Nigerian women over the next decade. Furthermore, we developed two intervention scenarios for expansion of family planning and PMTCT services. For family planning, we assume an intervention enabling to meet the unmet need for family planning and increasing the coverage of contraceptives to 31% over the next 5 years, and just maintaining that at a fixed level forward. For PMTCT services, we assume an optimistic interventions reaching the UNAIDS and PEPFAR target of 90% option B plus coverage for HIV pregnant women by 2023, and then maintaining at that high level forward. In this slide, I'm presenting the results for integrating HIV and family planning services. At baseline, the model projected an increase in the number of women of reproductive ages by 37% over the next decade, which further indicate the growing need for family planning services in Nigeria. After implementing the family planning intervention, which was increasing the contraceptive use to 31%, a model projected that the fertility rate would drop by 15.5% among women, bringing that from 6.5 children per woman to 5.5. This also resulted in averting over 8 million unwanted pregnancies over this timeline. Furthermore, we projected the impact of increasing PMTCT coverage up to 90% over the next 5 years. This resulted in reduction in rates of infants infection by about 56%, averting over 237,000 infants infection by year 2028. When we implemented both interventions at the same time, the combined effect was even greater. These interventions were able to reduce HIV incidence by 12% at a national level, averting over 300,000 infections, and reduce the HIV prevalence by 3.5% at a country level. Finally, we moved an analysis to understanding the role of integration in India. So India had the third largest HIV epidemic in the world that is mainly concentrated among key population groups, including female sex workers, MSM, and people who inject drugs. There is the HIV epidemic in India is marked with significant geographical variation, and the rates reported for each of key population differ significantly from one state to the other. The situation is similar in terms of prevalence of other STIs, including syphilis infection. So in these settings, we considered a scenario for integration of HIV and syphilis services for female sex workers and MSM in India. Using a spectrum package, similarly again, we considered a baseline scenario maintaining ART coverage at fixed level reported at current time for female sex workers and MSM and continue it forward. For the intervention scenario, we model community outreach program following a similar setting to Avahan program in India that targeted female sex workers and MSM over the next 5 years. We assumed that intervention was able to achieve 60% coverage among MSM and 90% outreach to female sex workers who were then tested for HIV and syphilis and received appropriate treatment with heterogeneous levels of uptake, and all of the estimates were taken from the literature. Based on these definitions, the intervention was modeled as a gradual increase in rate of HIV testing and ART coverage among each population group. Among MSM, this resulted in gradual reduction in HIV incidence up to 34% by the end of intervention period, which corresponded to averting more than 43,000 new infections and 59,000 AIDS deaths averted. The impact among female sex workers were marginal in terms of HIV incidence, given that at the baseline, the model projected a gradual decline in the rate of HIV incidence among female sex workers, at least at a national level. However, the results were still substantial in terms of mortality rates by reducing it by 81%, averting more than 6,000 deaths averted. We also implemented 2 additional scenarios by adding PrEP at lower and higher coverage levels to existing ART interventions. The addition of PrEP could further expand the potential impact of interventions on epidemiological outcomes. However, it was limited by the existing protective immunity induced by high ART coverage. Finally, in terms of syphilis, the intervention was projected to diagnose and treat more than 510,000 cases of syphilis amongst female sex workers and MSM in 2018 alone. However, given constriction of the model for simulating co-epidemics of HIV and syphilis together, unfortunately, we couldn't project these trends forward. In summary, integration is not a one-size-fits-all approach, and our results further indicate that finding the best methods of integration in each country requires a deep understanding of the factors driving HIV epidemic in relation to other health outcomes in that country. As currently envisions, our model projects that integration of HIV with other health conditions can substantially reduce HIV incidence in the targeted communities. It can have a marginal impact on HIV incidence in the country as a whole, and it will also have a minimal impact on HIV prevalence in short term. Despite this minimal impact, the interventions could be still cost-effective, as my colleague Brian will present to you shortly. And finally, one should take all of these results with care. I invite you to read the Commission report and also refer to our online appendices for the full list of assumptions and parameters that we used in this model. And we also have extensive sensitivity analysis around our results to further variation of these parameters. These results are not aimed to guide future efforts for exact implementation of these proposed programs in the population under study, but rather to provide a promise of success for integrating HIV and these healthcare services and inspire future research in this area. With all this, I thank our supporters in the international AIDS community, my mentors and supervisors at the Johns Hopkins University, including Chris and David Dowdy, and our kind supporters in Avenir Health who help us with calibration of this model, as well as the Johns Hopkins Centers for AIDS Research. Thank you for your attention.
Thank you, I'm sure you will agree that was a magnificent disclosure of 3 enormous and beautiful studies in less than 8 minutes. So well done. That was extraordinary. And Brian is going to respond now on the costing aspects of the modeling.
So good evening. It's great to be here with you. First, I'd just like to talk a little bit about economic evaluation, some of the benefits. Firstly, it's important for establishing what are the resources that are required for delivering these interventions and for scaling them up. So that's certainly essential information. But we're also able to determine, are these interventions cost-saving or cost-effective? And really, I think this is getting at the question, are we getting value for money? And by value here, what I'm talking about is preventing death and preventing disability. And third, economic evaluation can be an essential part of policy advocacy and for evidence-based decision-making. And I also want to note some limitations as well. So in addition to whether or not an intervention is cost-effective, we have to consider, is it feasible, is it affordable, is it acceptable, is it equitable, among other things. And also when we're talking about modeling integration scenarios, we have to be aware that the evidence base right now is not that strong. It's going to be wonderful to have more studies. There's more that are occurring that'll provide more information on impact and cost of these interventions. And briefly on methods. So in regards to costs, we're really talking about two pieces. What is the cost to deliver these interventions, and what are the impacts on healthcare utilization? We are using a payer perspective here, so there are also impacts on people receiving services, but we're not including that in these analyses today. We also estimate the impact of the interventions on reducing death and disability as reflected in disability-adjusted life years. And it's really the ratio of these two, the cost and the DALYs, that gives us the incremental cost-effectiveness ratio. What is it cost per DALY averted? And we can compare that against per capita GDP for a country to help us figure out, do we think these interventions are cost-effective or not? So I'm going to jump into the Kenya model. And here the intervention again is community engagement with HIV testing and NCD screening. And this is based on the search study that was done in Uganda and Kenya, and there are some results reported yesterday. But with this intervention, they estimate about $21 per person reached and screened for HIV. So overall, over the 10 years of this intervention that is targeting pretty much everybody in Kenya, we're looking at $625 million in terms of the intervention costs, increased ART costs of about $850 million. So in all, over 10 years, about $1.5 billion to deliver this intervention and pay for the increased healthcare utilization. So what do we get for this? As Parasatu described, we avert about 216,000 infections. We also avert 6.5 million disability-adjusted life years at a cost of $227 per DALY averted. And if we compare that to the per capita gross domestic product at the bottom, we can see that this is a very cost-effective intervention based on these analyses. If we look at adding on diabetes and hypertension screening to this, the supplemental cost is about $1 per person, so about $35 million over the course of the intervention. We would identify 7.5 million people with untreated hypertension, treatment costs of about $374 million based on our treatment cascade that we have for hypertension. So, and we would avert about 1.8 million disability-adjusted life years for a similar amount, $232 per DALY averted. Also highly cost-effective. For diabetes, we didn't have estimates that we had confidence in regards to DALYs and treatment costs. So here we're just reporting what's the cost per person identified with untreated diabetes. And here we have an estimate of $54. For Nigeria, we modeled increased coverage of PMTCT and family planning services, the majority of the HIV-related costs coming from screening. But again, we have a total cost of this program of about $1.5 billion. With this, we're able to avert nearly 300,000 HIV infections and avert 8.6 million DALYs in regards to HIV at a cost of $169 per DALY averted. Again, very highly cost-effective. For family planning, this is somewhat unique in these interventions that the healthcare costs averted nearly pay for the investment that has to be put in of $230 million. So it ends up costing a net value of $22 million and averts 23 million disability-adjusted life years. So that's only, by our estimates, $1 per DALY averted. So
Wow.
it's nearly cost neutral.
Hello. The crowd's still awake.
And then for India, we modeled the integration of HIV and STI management for female sex workers and men who have sex with men. And for the intervention costs here, we're not costing the full sort of Avahan package, but really thinking about using respondent-driven sampling to basically provide compensation to people to come in and be tested and to bring other people in to be tested as well. And that costs about $20 per person screened with HIV from research in India. So with that, the total costs of this intervention are about $1.8 billion. There's 2.7 million DALYs averted at a cost of $656 per DALY averted. And this is higher than for the other countries, but this is still only 1/10 of the per capita GDP in India. So again, this looks to be a very highly cost-effective intervention. For STI management, we really focused on syphilis, and we have estimates of what the screening costs would be and what the treatment costs would be associated with that for a total cost of about $318 million in the context of these other services for HIV. 2.4 million DALYs averted at a cost of $135 per DALY averted. Again, highly cost-effective. We also looked at PrEP, and PrEP was not cost-effective. At $91 per person per year, it's about $58,000 per DALY averted using PrEP. So it may work for particular subpopulations that we may have in India, but at a national level with these populations at this price, it's not cost-effective. So that's a quick run-through of the costing and the economic evaluation that we have here. And I hope these analyses get you excited about integrated scenarios and that you can imagine engaging with providers, clients, advocates, and policymakers about integration. And we provide but a few illustrative examples of integration, and we believe that integration can take many forms. However, to echo what Parastu says, we have to attend to context. So what's going to work in particular situations? What are the epidemiologies of HIV and other diseases in these different places? And also, there are many other health conditions that can be addressed in concert with HIV, including cervical and prostate cancer, TB, malaria, viral hepatitis, substance use, overdose, vaccination, and mental health, to name just a few. And just in conclusion, I would just like to repeat what's said in the report itself, which is the potential benefits of integration are substantial, but they are only realizable with the bridging of now siloed healthcare strategies. And finally, I want to acknowledge and thank my collaborators, and I also want to thank all the commissioners and just the wonderful experience of working with them and having their feedback and guidance on this process as well. So, thank you.
Thank you. I think with that, just a huge round of applause for an unbelievable amount of work that these young investigators have contributed. And I will ask them now to leave the stage. Thank you very much. This is the point at which we dialogue with you, and we want to bring on board some of our commissioners to be discussants. But as Pam said, and Pam also poised, so please do come up, you know who you are, while I'm going to introduce you. Chris is already on stage, just to come and join Chris. But Pam posed some very significant questions that I hope you've been thinking about. You may have some more, but we really do want this to be a two-way dialogue. At the end of this, we'll sum up what the plan for the Commission is going forward. But I want to, at this point, welcome Jeff Garnett, Deputy Director, Data and Metrics Integrated Delivery, and he comes from the Bill and Melinda Gates Foundation. Jeff, in the interest of time, I'm going to leave it there. Nduku Kalonzo is a plenary speaker at AIDS 2018. I hope you really enjoyed what she had to say on Wednesday. She's also Chief Executive Officer of the Kenyan National AIDS Control Council, and therefore really represents implementation, policy, and is also an extraordinary doctor in own right. Keleso Makafani is a South African, currently a PhD candidate at Harvard, and he is studying biostatistics, but has also been intimately involved in community in his past life, and wrote, or primary author wrote, one of the commentaries that you also see in your Lancet Commission with a view from the community. Lois Pace is the President and Executive Director at Global Health Council in Washington, D.C., and is really a leader who's worked on the ground in more than 10 countries, delivering health programs and mobilizing advocates. She's also had a leadership role at Livestrong Foundation, amongst others. So I really want to welcome this fantastic group of people. And whilst you are thinking of questions, comments, and coming up to the mic, I'm going to really just ask each of our discussants to reflect on the Commission, its process from their various individual perspectives. So Lois, I'm going to ask you to start on the end there, to just really, you really are sitting within the global health arena. Do you want to just give a sense of your perspective?
Sure, Linda Gail. I feel like I'm a bit far away from things, but first of all, I'd like to thank you all for being here for this, and obviously offer my regards to co-commissioners. I really have been grateful to have been a part of this whole process, and yes, Linda Gill, you're right. Coming from the global health community, this is a different kind of space for me. We kind of look at all this from a 10,000-foot view. But I've been spending time this week really trying to listen to some of the conversations that I've been a part of that relate to this topic of integration, and so I'd like to share a little bit of my reaction, not just to the report, but kind of to the discussions this week. First off, I think everything has to start with the people. And you all in this room know that. I think people across the global health community understand that, and I do think it's important, though, that we acknowledge that first and foremost. And I don't think that is sort of incongruent with some of what we're talking about here. In my experience, frankly, having worked on the ground, and when I was working in the non-communicable disease space mainly, I heard a lot from patients themselves, from cancer survivors, who were really talking about sort of comorbidities across the spectrum, and their desire for us in the global health community to be more coordinated in the services that we provide, and the advocacy that we do on their behalf. And so I would like to think that some of what we've presented in this paper would be welcomed by people on the ground. In the same vein, I spoke with people living with HIV who had sort of the reverse conclusion around being affected by some of the comorbidities that have been presented throughout this week. And so I'm really grateful that we're keeping them in mind in our approach. I think related to that, I've heard a lot this week, obviously, about key populations, and I want to acknowledge that there is some anxiety there around whether what's been proposed by the Commission sort of sets us back or puts those groups at risks. And so I think that we should absolutely be mindful of that, and I think that's well presented in the paper. I also, though, want to say I think there's an opportunity that we're not seeing potentially. So this idea of key populations or special populations, or however we want to frame them, really is not unique to the HIV community either. And so that does exist also in other global health priorities, perhaps in somewhat different ways. But some of these other priorities and issues really are grappling with that same sort of tension, with that same concern. And so I heard Peter Piot today talk about migrants or refugees, for example. I also know that adolescents is a special population for a lot of different global health priorities. And so to me, I envision a time whereby we're able to bring the voices of all these key populations to bear. I mean, what if, for example, we could sort of pool this activism from across the global health spectrum in a way that benefits them holistically, in a way that benefits them sort of comprehensively. Again, I think I would want to hear from members of those populations to react to this and to tell us if that's feasible, if that's doable. But I would really love to explore something like that, because I do think that we could really see a lot of power emerge by I guess, broadening the tent in that way. So that's one area I wanted to touch on. I think another thing that came to mind this week is the fact that, you know, this isn't really new, and we see this in some of the modeling presentations. But you know, we've been integrating. This is sort of a natural progression. And so, as I sort of participated in this process, I thought that this was a bit more about sort of formalizing that, or being more intentional about how we go about it, and sort of setting a course whereby we can do so. So I hope. Hopefully that sort of lets the air out of the balloon a little bit as well. I mean, we even see programs like PEPFAR actually talking about how they have helped build health systems in countries, and we've seen the benefit of that in country. We've seen the Global Fund also provide grants in that regard, and so I think that we should embrace those examples as, again, opportunities for us to really look closely at what works, what might not, and how we can bring those things to scale in a way that's really helpful. I'll stop there because I don't want to go on too long, but again, thanks for having me, and I'd love to hear from others here and others in the room, their thoughts.
Thanks, Lois. I think that's just fabulous. And I'm going to turn the mic now because, Lois, you raised that, you know, and I think throughout the Commission, it really does call for that patient-centered approach. So, Keleto, putting on your community hat and representing the key pops that Lois was just sort of talking about now, do you want to just reflect a little bit on your perception of what it is we're trying to do? I mean, that's quite provocative. Is it all done? And are we actually, you know, what do you think about that?
Good evening, everyone. I had prepared a story because I speak in stories, and I'm going to abandon that a little bit and try to respond to, firstly, this idea of community hat. I am a biostatistician, and I'm training to be a social epidemiologist. I trained to be an actuary, and I've kind of intervened in peer-reviewed literature through these lenses, really focusing on access to services and homophobia and stigma, and how those play out in the lives of gay men and men who have sex with men. So there's something about community hat which really delimits my contribution to feelings and voice instead of scholarship. And I think there's something kind of to dig into there, and there's something peculiar about HIV in this kind of paradox. On one hand, there is space for these interventions by community people who think community thoughts in a way that's expansive and helps us to respond to the myriad social factors which drive this epidemic. At the same time, there is a box in which these community thoughts are placed, which puts it on a hierarchy of the generation of knowledge below, like science or whatever it is that I would be if I weren't a community person. This is not to like.
Well said.
I'm not combating you, Linda Gale. I'm trying to kind of, on one hand, respond to this box, which is a difficult box, but also respond to some of the comments you were saying about how ideas about key populations and the patient-centered response might already be there in the global health response more generally. I think if we say that, we are kind of diminishing something very special, something peculiar, something unique, something beautiful about the HIV response, which is different. The HIV response began in communities who were under siege. The last time people were in the city, there wasn't heart, right? People died. I've been with friends who have been filming with their activist friends who are here for the second time in Amsterdam at this conference, and their friends died, but they responded and they took care of each other. So I think that makes HIV a little bit different, and that might be a way of thinking about what could the global health enterprise benefit from by looking at how HIV has evolved as a response. Now, I had a very long story about even expanding further and thinking about inequality and dreaming bigger dreams. You know, like what we want is not a fully funded HIV response. We want that. It's an emergency. People are going to die if there isn't a fully funded HIV response. But we want a world where there isn't HIV and there isn't inequality and people have enough to eat, have shelter, have things that dignify human life. And I think one of the limits I wanted to speak about through a very long story is how we don't talk about the things that create inequality, the people, the processes that create inequality. How about an RCT on a behavioral intervention on US Congress members reducing their capacity for this jingoistic impulse in American foreign policy? How about an intervention to get rich people, wealthy individuals, to support each other, a peer-led intervention, to support each other, to pay everyone in the supply chain a living wage? How about that? I think, so yeah, on one hand, the key populations in HIV response is amazing, it's beautiful, we shouldn't diminish it, it's unique, there's lots to learn from it. And on the other hand, thinking about problems of inequity through a very narrow HIV lens misses the opportunity for the HIV response, which has a moral authority that other other health enterprises don't have. It gives us an opportunity to think more broadly and to insist on a different kind of world, a world where people have what they need to live.
Thank you. Nduku, from your perspective.
Thank you very much, Linda, and it was an honor to be a part of this commission. I think my reflections are threefold, and the first one is just coming back to the question of integrated care model. And the question I ask myself is the recognition that in addition to the data that we have that is important and has been presented to us, is the fact that actually the idea of integration is intuitive. This is something that we have talked about. It makes sense to do. We now have the data about what it means for costs and cost effectiveness, but it is simply a sensible thing to do. The challenge, though, and I am putting it out there, is the challenge around the extent to which it becomes less of the most sensible thing to do with the highest cost effectiveness or with the level of cost effectiveness, and becomes a political conversation about the resources that are available and what they are earmarked for and what can be done and what cannot be done. And I think really that is a real issue in terms of taking this work forward. The data that has been provided for us gives us, and let me speak about myself as a policymaker, an opportunity to be able to get more people around the table and say this is more than intuition. This is a sensible thing to do in view of our NCDs, our hospital admissions. But there is then the next question around how to depoliticize that discussion and actually make it a practical discussion around, for the 11 million tests that we do in Kenya for HIV, how do we integrate, diabetes tests, random blood sugar testing and hypertension tests? How do we do that? It is simple, it is possible, it is effective. If we depoliticize the discussion and move it away from money and earmarks and make it a reality about what needs to be done. My second comment has to do with some of the thoughts that I presented yesterday around the idea of what can be done by other sectors. And I think we have moved away from a multi-sector approach and action in other sectors and really come back to the health sector. Yet we know the whole idea of HIV transmission, sex and sexuality happens outside of the health sector. It is in parties, it is in communities, it is in everywhere else, but not in the hospitals or the health facilities. And just thinking, for instance, about when we looked at our data, infrastructure projects, and I did, and being able to say, how can we leverage the fact that every infrastructure project that I know in Kenya, in sub-Saharan Africa, and actually most of the world, has a budget line for mitigation of health impact, of negative health impact of this infrastructure, and leverage that to deliver a standardized approach for HIV prevention and services. And in addition to that, and I'm sure if we did look at NCDs and infrastructure, I am pretty sure you will find some sort of relations. And it is common sense that where you get migrant workers, you are going to get certain levels of certain types of NCDs emerging. And so it comes down to begging the question of when do we actually start to make action in those sectors and going beyond the health sector and saying it is not easy, but we are going to invest in working in those sectors. And I think this is the opportunity. And the third and last comment has to do with the place and how the place of Africa and more Africans in these deliberations. And because I think where I come from back home, we know the problem, we know the challenges, we know the opportunities. It is also about being on the table when the discussions are happening. And I think I did raise this before, so that we can really be able to say, if we're going to make this happen, we make it happen in the way that works best for us, is most cost effective, because that is the way that we are all going to be able to move forward. And yeah, so I think those are my few reflections in terms of what we do with this report, what it means for me, and how we take it forward.
Thanks. Jeff, I'll ask you to reflect, and then I'm going to throw it open to the table.
Okay, thank you. Well, Pam mentioned at the start the anger that infused the response to HIV, and I want to remind us that we were dealing with an infection that was 100% fatal, and the response was initially slow and mean. And that led to that anger. Since then, we've seen a fantastic, successful response, but we need to remember there's heterogeneity in that success. In some places, we're very successful. In other places, it's not yet. So we've still got work to do in responding to HIV. We hear about a transition in HIV where incidence is less than mortality. And God forbid that we have that because mortality is greater and growing bigger. But there is that transition where prevalence will decline if incidence is less than mortality. But it will take a long time, and the less incidence is, the faster that transition will take place. And until we develop a cure or a vaccine, we don't have a cure or a vaccine, this epidemic isn't going to go away without us maintaining our interventions. We need our treatment and prevention interventions to stop incidence from climbing again. So why, with all that, are we talking about integration? Well, I think partly integration is a way to help us sustain our response to HIV, to facilitate the institutions, the health system to actually manage patients who are HIV infected, and to promote HIV prevention. So it's that, but it's also a win-win. If by doing that we can actually deal with other health and social problems, then we should take that win-win. We are working to simplify HIV treatment and prevention and testing with differentiated service delivery, which I think is great because we need to give patients and clients what they want and services that will support them and help them. And that's why we should be offering other services as well. I do think that as we take the response to HIV forward, we need to be thinking about community ownership and community delivery of services. And this is mentioned in the report. And I think it's something that we haven't done particularly well, allowing communities to own the response and coordinating service delivery with the communities. And I think that's something that we can take forward out of this report. Finally, I just want to remind us that Nduku said it, we're talking a lot about healthcare delivery, but we also need to be talking about health promotion and HIV prevention and the prevention of the diseases. And so as we think about the community global response to HIV, I want to encourage us to think about health promotion as well as just treatment. Thank you.
Thank you for that. I'm going to ask if there are comments from the floor, so please. Could you just say who you are, where you're from, and if you direct your question to a particular person or to the panel at large?
Sure. My name is Jose Antonio Isasola from UNAIDS. I'm from Mexico. I have one general question, and I believe it has been partially touched by some of the panelists. But it seems to me, and I will read the full report very carefully, do get it from there. But it's, at least from these presentations, it's not very clear to me what's the main rationale, the main motivation of integration. Is it for the sake of the efficiency of the health service? Perhaps that's good enough. But what's the implication for the people? It's for the individuals, for the communities. Do we have that clear? For example, in some AIDS-dedicated facilities in concentrated epidemics, and allow me to use that terminology, perhaps the stigma discrimination, the rejection by some healthcare providers is not properly managed when they see someone living with HIV for the first time. That's what was the motivation to have AIDS-dedicated facilities in some places. But this integration might need to have these startup costs. How was that analyzed here? And a second comment, perhaps going back to the first part of the models. I believe I like models very much, but some of the assumptions that we take might influence some of the results.
Sure.
I was wondering, for example, out of the 492,000 individuals who would be diagnosed with HIV in South Africa, why would only 40% of them initiate treatment? Or in India, the community outreach, as presented, was the same for sex workers and MSM. And I believe for outreach purposes, I could not think of two more different communities. And finally, for PrEP, it was not cost effective, but it was analyzed separately for each population.
Mm-hmm. Thank you. Chris, do you want to take a sort of brief stab at some of that?
Sure. Well, I really encourage you to read through it, and you know, good to see you. and I think particularly for folks like yourself who are interested in modeling, the supplemental materials really go into those details. And because it's late on almost the last day of the conference, maybe the rest of the audience might not want to hear this. But let me just say one or two things that I think are helpful. One is, overall, these are not meant to be definitive models for planning purposes for Nduku and her community in Kenya, right? We are really trying to take examples where there are problems in the HIV response, like the very high numbers of infants being born with HIV infection in Nigeria, and where we know there are also issues in, for example, contraception, family planning, and reproductive rights and services for women in Nigeria. And taking that as an example of one way to look and model. I would also just say to you that and this is quite important, I think, you heard a number of different presentations. We actually used quite site-specific models for each of the scenarios, so don't try to compare, for example, the Russian modeling approach with what we did for Nigeria or what Lee has done with South Africa. They're different models, they're different scenarios, and they really are meant to be, I think, provocative and illustrative, and don't try these at home.
Thank you. Thanks. I'm going to actually ask that we maybe take a couple of quick there and one here, and Lois. Okay.
Thank you. Sorry, I just wanted to chime in because I think this is an important point to drive home. So from my perspective, in terms of why we look at integration versus just doubling down on what we have been doing, it seems as though it's been a challenge to continue doing things the same way. And Pam talked about business as usual and challenging us around that. I think that applies somewhat to sort of the programs themselves, but I think it applies more so to the funding landscape and the political leadership that we're up against right now. We talk at Global Health Council about being in a new normal. And this paper sort of puts out there this idea of AIDS exceptionalism, but broadly we talk about the golden age of global health changing and potentially going away. And so I think that is what drives me to be thinking about what all is in our arsenal. It doesn't mean that what we're doing currently goes away entirely, especially if it's working. But I think, for example, to push for more funding in a climate where we've seen that flatlining and even declining is not the sole option that we can exercise. And as we get closer to the finish line in this fight, and I think we're all invested across global health in this, we have to be. You know, I'm a runner, and so it's like once you like get to that 20th mile, you want to pull on all you can to get across it. And so this is actually pulling from that in my mind. It's really putting out something else that we can use potentially that will help us get over the hump, especially for groups that really have been left behind in the response. So I just think it's really important to call that out, and I'm glad you asked that question in terms of like understanding what we're all up against.
Thanks, Lois. I'm going to ask one and maybe two, and then see where we go from there.
Yeah, thank you. Michael Boyven from Michigan State University in the U.S. Please don't hold that against me. Yeah.
Just keep it short.
In costing the benefit of integrated services with, say, cost per disability-adjusted life years, using models like Spectrum, it's really tempting to go with really discrete diagnostic conditions, hypertension, syphilis, opioid debts, diabetes. But I'm thinking across all these different country scenarios, mental health, yeah, and early child development. I mean, children outside the context of simply family planning, right? Those are messier categories, but perhaps of sweeping significance and impact, but yet we may not as readily incorporate those into our models because they're a little messier, yeah? So I just want to challenge the panel to consider those potentially high impact, universally applicable domains, and there are others. I've just named a couple examples, and get, as appropriate, the panel's response to that consideration as you model integrated services economically.
Thank you. Thank you for that comment.
Jorge Saavedra, it's Healthcare Foundation, Mexico as well. My question and my comment is, when I was the head of the National HIV Program of Mexico back in 2003, 2009, in 2007, it was very popular, the trend to integrate. So many people from the government were pressuring me to integrate family planning services with HIV services. And back then, family planning services were thousands, used 90% of them by women, and HIV services were dozens, 80% used by MSM. So for me, it didn't make sense. I mean, if you integrate both, then the ones who will be suffering will be MSM. And so I oppose, and still not integrated both. I know that for sustainability purposes might sound right, but probably it also depends on the epidemiology of each country, prevalence rates on different sectors of the population, whatever makes sense for South Africa and some other countries in sub-Saharan Africa, it might not make sense for Latin America with a different epidemic.
Thank you. I'm going to ask the panel to hold on to something because we're running a little out of time. Can you keep your questions quite short? Thank you.
I would like to thank you very much. I'm Gisela Schneider. I'm a public health physician, and since a long time been in HIV work, now more in global health. And I was really delighted to hear your discussion, to read this paper, because I think we are at a point where the two movements have to work together. Because only when we move together and create the synergies, we'll be able to mobilize the resources, local, domestically, and internationally. And I think at the heart of everything is the community. And I was very delighted to read here in your comment that you went back onto the Alma-Ata Declaration. And I think that's the root of everything. If we implement what Alma-Ata has declared 40 years ago, and you're talking about the new international economic order, we are talking about solidarity, we are talking about more justice. And I think we also have to listen to people in the South, asking us in the North. We haven't really dealt with the pharmaceutical industry, we haven't dealt with trade and things like that, and I think we have to go for the whole thing at this time. And we've got one big chance. I know we are in a crisis, we all need the resources, and there's people dying out there, dying of HIV, but there's many other issues. There's maternal health, I'll be soon in DRC, lots of other issues. And I was really delighted. And I think if we create the synergies between the HIV movement and the global health movement, locally and internationally, we can really mobilize
Well
something.
done. Yeah.
Thank you.
Thank you. Great comment. I'm going to go to the back mics, just to hear what you have to say.
Yeah, thank you very much. Etienne Kadima, I'm from Botswana Harvard Partnership. My question is in connection with the health financing model for low and middle income countries. So I would like to know, we've been relying on the funders, sponsors to finance the health care delivery in low and middle income countries. And as we can see that now it's those assistance or whatever is going down. So I would like to know what can be advised to low and middle income countries in terms of a financing model. Should we continue with, like in some of the countries, like where I'm coming from, where the government is taking care of the health system, so ARVs are provided free of charge. But as time goes on, we've got a large number of patients who are on treatment, and the government is no longer able. So should we continue with that model, or we should now introduce the out-of-pocket, where we ask the patient as well to share the cost of those ARVs in low and middle income countries, and what could be the impact of that approach on HIV incidence?
I think we've got it. Thank you very much. I'm going to give you, can you please keep that really short? Sorry to limit you.
No problem. Margaret Hallard from the Burnet Institute in Melbourne. Really interested in the process that was used to pick the diseases that we lined up with. And for me, it didn't necessarily make intuitive sense. If one thinks about integration of communities, then they weren't necessarily the diseases speaking to those populations and communities. If we think about prevention, we'd say, what are prevention interventions that could be integrated? They didn't intuitively make sense. Say India and sexual health might. Similarly, in terms of testing and similarly in terms of treatment, I was very surprised there wasn't an integrated model looking at hepatitis B in one of the African countries or hepatitis C. So I'm wondering, what was the process going through people's minds in terms of choosing diseases? Because if we want to win this argument of integration, we actually have to think of the low-hanging, most cost-effective arguments to win rather than sort of somewhat random approaches. I'd be really interested in that.
Thank you. Thank you. I'm going to ask any quick responses to the questions you've heard. Can I see some hands? Quick responses. So Kaletso and then Nduku.
So I'll just say two quick things. The first is about integration and what we actually mean when we say that word. I'm not super clear. I've been in a setting where there was a government clinic staffed by an NGO and connected to the community through an NGO-run outreach service. Is that an integrated service, or is that a standalone service for that key population? So if we define kind of the terms of this debate, we might have a more productive debate. The second kind of quick comment is about the Alma-Ata Declaration and the idea of universal health care and kind of the transformation of the circumstances which create health inequity. I think we get closer to that language when we start speaking about integration and figuring out how to get services to everyone who needs the services. But what we are avoiding this time around, which I tried to point to in the comment that was published, is that the Alma-Ata Declaration was predicated on a political project to transform relations between poorer countries and richer countries, those relationships which were inherited from colonization. And if we don't kind of engage those political things that create inequality, as the people who work on intellectual property and drugs do, so we have to acknowledge that people do that in the response. I don't think we do it across, broadly speaking. But we can't avoid those political conversations and think that we will change inequality if we believe that inequality is a driver of the HIV epidemic as we see it. So I think some of what I was pointing to is that we are avoiding very political and difficult conversations through technocratic language, but it's kind of important to engage those if we're serious about inequality.
Thank you. Thank you. Nduku?
Just making it very brief, I think I just want to make a key point. When we talk about our healthcare services and them being funded fully by donors, I think often when I think about the HIV response in Kenya, the healthcare workers are paid for by government, the infrastructure, all the treatment clinics, 8,000 of them, whether EMTCT or ART, public health, a few private sector, but essentially the ones that provide treatment are government, the infrastructure is government. So yes, we do get funding, particularly for commodities, but I think we need to recognize that there's already a significant government investment that goes into these programs. That's the first thing. And then the second thing is just to say that the next question becomes, so what are the opportunities within the government financing? And those are places where I think I did talk about some of the areas where we can get resources. Because the reality is we will have to find places where we can get savings, 1, 2, additional funding to be able to cover some of the gaps that are going to come with the decline in funding. And therefore, this integration may be about that on the one hand, but on the other hand, it is also about the person who goes to a facility and doesn't have to go from the ART clinic to the clinic that is looking at diabetes to the hypertension clinic, in the same clinic in 5 different points. It is really about trying to say, when I come in, what do I get?
Yeah, we hear you. Thanks, Aduku. We're at the end of time, so I'm going to ask Pam, as the host of our commission and partner in this, is there a second last comment you'd like to have? Because I'm going to give the last word to Chris.
Okay, well, thank you everyone for coming tonight, and it's been really interesting hearing the questions and the discussions. I think really the next steps are going to be quite critical. And partly the success of this commission is how we engage the two communities. We're here at an AIDS meeting, so primarily many of us here are in the HIV/AIDS field. So now we have to reach out and connect with the broader global health communities. We've done so to some extent in the commission with some of the commissioners we have, but now we have to really go out there to the communities. So I look forward to how that process is going to come about, and yeah, look forward to seeing where this takes us.
Thank you, Chris.
Thanks. I guess I would just add, going forward from that, Pam, that the Commission is impaneled for at least another year. This is an IAS Lancet Commission, and since all of you are IAS members, it's nice that we followed on from the IAS members meeting. You're all very much invited to participate, to send your thoughts and ideas along. There was a comment about all the other domains. So if you have the time, maybe on the flights home, for those of you who are flying, look through the second part of the report where we really talk about many of those domains, including mental health and substance use and others that didn't necessarily get fit into the modeling. And finally, I would say that we know that we have a great deal of work to do building bridges, the theme of this conference, as Pam said, with the global health community. We also are going to do a series of regional meetings and relaunches in a number of places. Those are primarily going to be supported by the Elton John AIDS Foundation. We're going to do one in Washington, D.C. We're going to do one in Moscow. We're planning on one in Cape Town, and we certainly would invite your engagement, participation. We really see this as we hope, an opening of just what's happening here, a dialogue, a debate, a discussion, and hopefully putting forward some ideas about the next phases of research, of implementation, of work that can be done to achieve the goals that we all share, which is a world where people have access and more access to people-centered, human rights affirming and evidence-based approaches to more comprehensive health needs. And where those things can happen as we improve the HIV response. So I just would ask you to join me in thanking these panelists and my co-chair, Linda Gale. And thanks.